Hello, everyone. Welcome and thank you for taking out time for this session today, where I will be taking you through through the ABDM ecosystem, its vision, its guiding principles, and how we can be a part of this ecosystem and further help and provide better healthcare to our citizens. So in the later part of the session, I will quickly walk you through the process of ABDM integration and its journey. So before I proceed ahead, I would like to introduce myself. My name is Dr. Shabnam. I'll be having my colleague over this session, Mr. Sachin Yadav, and we both are working in NHA into ABDM integration for private entities. Also, before I begin, I humbly request you all to keep yourself on mute. You may unmute yourself or use raise hand feature. Whenever you have any queries, we'll take it forward. This session has been recorded and recording will be uploaded in our Sandbox ABDM website, and it will be seen over the menu resources webinar section. So let me share my screen first. I hope the screen is visible.
Yes, it's visible.
Yeah. So I'll give you an overview about Ayushman Bharat Digital Mission. ABDM is a flagship program launched to create a digital ecosystem for our country's healthcare sector. Vision was to create an ecosystem that would support universal health coverage in an efficient, accessible, inclusive, affordable, timely, and safe manner. So this will be achieved by provisioning of wide range of data info and infra services, leveraging open and interoperable and standard-based platform, ensuring the security, confidentiality, and privacy of the health data. So the agenda for today, we'll be having the vision, the guiding principles, technology stack. The terminologies will go through the registries, the ABDM facts and myths, what role you will play in ABDM ecosystem, ABDM sandbox integration process will go through, and a bit of milestones and the Q&A. So I have covered the vision here bit. So ABDM aims to act as a inclusive network for citizens, healthcare providers, basically all the stakeholders to have seamless access to the healthcare digital services. So keeping in mind this vision, there are some guiding principles followed. So ABDM is based on federated architecture, that is data resides at the source where it is currently residing. That is the hospitals, the clinics, or the doctors. So this data at source may be accessed by the open APIs, making interoperability, and where registries, that is HFR and HPR, which we'll cover later on, that is Health Facility Registry and Health Professional Registries, this would act as a single source of truth. So all this is supported by technology ensuring inclusivity and privacy by the design, basically aiming at improving the overall continuum of healthcare. So why ABDM and what it tends to solve, the purpose of ABDM? So here we can see for the citizens, they can check the availability of medical resources wherever they are, discover the health services and the products, book health services appointments or the health products online, avail teleconsultation, video consultations, and other health services and products. For healthcare providers, what they do, they will access and view the patient history. The longitudinal and vertical health records can be shared with the healthcare providers and provide digital health consultations to the patient, and of course to provide the primary healthcare. For the policymakers, they can view and analyze public health at the national level. They can analyze the data and implement policies effectively at even the local level. So we have the framework next, the core principles, the principles which I've already discussed, that we have open-based API, and it uses open standards such as FHIR standards. So FHIR standards is something, you have like 7 modules, like discharge and wellness, immunization. These are the modules, OP consultation, which you have to inculcate while you build the APIs, the milestone, when you go and integrate. So where you can share records. So record sharing cannot be done in just normal format. So all the records, either it's the discharge summary, the OP consultation paper, the immunization record, wellness record, it should adhere to a standard, that is FHI standards. For this, you can check out an RCS site where there are bundles, where there are standards given in a wide variety. You can go and check and implement the same. So the next is scalable and interoperable. Of course, I know microservice based scalable, both horizontal and vertically. It can be shared. The data can be shared, and interoperability between disparate solution. Disparate solution means the HMIS, the LMIS, EHR, and other solutions which you are using. It is federated and secure. Of course, data stays where the data is created. Of course, ABDM do not store any data. Data will be stored in the hospitals, the clinics, the HMIs, LMIs, the software itself. And of course, it has a consent-based mechanism, like without consent, the data cannot be shared from the patient to the doctor or any other facility. And yeah, this is how the security and the confidentiality is maintained. What is it is inclusive of? It is inclusive of all kind of citizens across the country, across geographies, and digital literacy. Assisted modes of creation of ABHA is there, which we'll cover later on. And offline ABHA generation in areas where there is no internet connectivity is also there. Now I'll come to some of the terminologies, which after that we'll cover the architecture. Okay, these are the terminologies which you will come through in this integration process of M1, M2, and M3 milestone. First is the ABHA number. ABHA number, you know that it is a 14-digit uniquely generated for each citizen. It's a unique number generated, and patient gives the ABHA, and the HCP, that is healthcare provider, will recognize immediately who the person is, since you are having only one number for the identification. It is a unique number for identification, and every citizen will have the ABHA number, and hence this avoids the data redundancy, and your database is cleaner and consistent. The ABHA address is also created by the system, which can be defaultly created, or you can create yourself, just like an email ID, and you can link the ABHA number to the ABHA address, of course. And ABHA address is created because all the health data, the records will be stored in the ABHA address, not the ABHA number. Then comes the health information providers, the hospitals, the clinics are the providers, and the health repository providers, HRPs, which are very important. These are HRPs specifically, they manages the, this is the one which manages your HMIS, LMIS, or any kind of, software. So next come the HIU, that is health information user. The user will be using like the citizens are considered as the HIU at times, and also at times they are considered as HIP also. Then comes the gateway. Gateway is something, it's a hub that orchestrates the interaction by the CM, that is the consent manager. This hub that orchestrates the interaction by CM, also by the API bridges, the HRPs, the HIPs in ABDM ecosystem. So it authenticates and within the framework, including the communication via asymptomatic APIs. So then comes the consent manager. Consent manager is all about when the data is exchanged, then the consent managers helps to notify taking the consent, like when the patient will forward a consent, or that, okay, this health record can be, accessed or viewed by this doctor, by this hospital. Then consent manager works here for sending the notification to the hospital, to the patient. Then comes the registries. In the registries, you have the health registries, health HPR and HFR, health facility registries, and HPR, health professional registries. And for example, when you go for M2 milestone, when there you have to go and link your facilities, go and onboard your facilities in the HFR first, so that you can link the records to those facilities. So without onboarding, without logging into the HFR, you cannot move on for M2 integration. And then comes the HPR. HPR is also, you have to log in to the site, and you have to get your HPR ID done. And we'll move on in the next slide, a bit more detail about HFR and HPR. And we have also our webinars coming on, and also webinars uploaded. More in depth, if you want to learn about HFR and HPR, you can go and attend those webinars. You can check those webinars, and also in our documentation section, we have broadly documented about HFR and HPR. Now I'll cover the architecture part. So now, since you know what is repositories, that is health repositories, and what is HIP, HIU, gateway, and CM, so you will better understand the architecture quite easily. Okay, trying to keep the architecture illustration very simple. So all facilities are exposed in ABDM via open APIs, as we all knows. Okay. So it does not matter what digital solution your hospital has, or if you have a single hospital, or you have a multiple hospital, or using multi-tenant architecture, or having a centralized server, all is okay with ABDM, right? So ABDM is a federated architecture. That is, our ABDM gateway does not talk to the hospital. Instead, it talks to the endpoint URL, which identifies the health repositories. So this health repositories is the one that manages your softwares, like the HMI solution, the LMI solution, whatever health tech solution, the PHRs, etc. So if you see here, ABDM does not at any point even hold or know what kind of health record is there. It is only the repository which will hold the health records. So when, in the data flow, which I just want to go through, walk you through a bit. So when the HIU, the health information user, seeks records of the patient, means the hospital seeks records of the patient, then the HRPs, these repositories, it notifies the gateway, which then seeks consent managed by the CM, which talks to the gateway. So gateway in turn notifies the HIP, the health information provider, for consent, who starts preparing the data. Meanwhile, the gateway also notifies the HIU, which sends the data push URL. So this URL is then shared with the HIP, who sends the data here. So in this way, the data exchange happens between the HIP and the HIU. So once the data sharing is done and it's been acknowledged by the patient, and after acknowledgement by the patient, it will be notified to the hospital, the doctors, that data has been acknowledged for sharing. So this is how the process goes on, the data flow process, it goes on. Okay. Next comes the ABDM technology stack. Here we have 3 layers: the user application layers, the specifically the gateways and the protocols, the service enabled. So user application, you can see there's diverse user experiences and innovative solutions, where there is HSPA, hospital service provider application, and user application. There are personal health record, PHR, HMIS, LMIS, and the provider and payers for the insurance sector. For the gateways, we have unified health interface the UHI. This UHI is an open network designed to enable interoperable digital health service delivery. So patient uses this platform for any kind of digital health services. Might be, discovery of a doctor, booking appointments, discovery of lab, discovery of any, if patient wants some blood, blood bank, discovery of pharmacy, is there any bed availability? So this unified health interface is a open network which patient can access for any kind of digital health services. Next come the health information exchange consent management, which I have already mentioned previously in the architecture, that how HIECM, that is consent manager works. And here the health record data sharing with consent is done. Health documentation collation is done, like diagnostic reports, prescriptions, everything will be, everything can be shared by HIECM, and aggregated health data for policy and analytics can also be used at the policy level. Then comes the health claim exchange, that is HCX platform, where health claims are processed. And this is a different platform. This is we have another team for this, and we will be having upcoming webinars for HCX completely, so you can also attend for the same. Okay. Okay, this is the ABHA card. And yeah, we'll have the patient name, the ABHA number, the 14-digit unique number, the ABHA address will be shown here, date of birth of the patient, gender, and mobile number with a QR code. So health ID is renamed now as ABHA number. So please make sure not to confuse it with health ID and ABHA number. And it is unique, and it has 14-digit number. 37.16 plus crore ABHA is created till date, and ABHA generation currently done by Aadhaar and assisted mode, that is driving license. Development is in progress for ABHA generation by passport and PAN. Passport and PAN is yet not live, so you can only create ABHA by generating currently by Aadhaar and driving license. Development in progress for child ABHA is also under process. Opt-in, opt-out feature, deactivate and reactivate feature of ABHA is enabled now. So yeah, this is the ABHA app, how it will look. So 1 million plus lakhs download as on date, allows user to maintain, view, share, store, manage records. So consent management here empower a user with complete control of his or her data when as I discussed previously, that how consent management will work, and how it helps to give the control of his or her data privacy, like whether to share or not. We have QR code enabled profile and record sharing using ABHA app for making all the interaction at health facilities seamless. Updated Android version released with simple and intuitive UI design. iOS version is yet to be released. And we have 5 PHR apps and 2 PHR web available being used in ABDM ecosystem. ABHA app, Arogya Setu, Briefcase, Eka Care, Paytm, Practo app are the 5 PHR apps available and live now. And for ABHA web, we have Raksha PHR web and ABHA PHR web. So next we have ABDM registries. That is HFR and HPR. As I've mentioned that you can visit to facility.abdm.gov.in for the detail about facility registration. So in milestone 2, you have to, of course, onboard the facilities for facility to get registered, so that the facility can be linked and data can be shared. In the same way, we have health professional registry, where you can go and have your health professional ID over there. We have ABDM live dashboard also, that is dashboard.abdm.gov.in, where you can see the live data. For example, if somebody is live, we have entities who have gone live, which are 105 plus. So we can check the data over there, like how many of ABHA they have created, how many they have linked the facilities. All the data can be analyzed from there, and it can be used in analytics and other purpose also. Some of the ABDM facts and myths which I'll cover. So some of the myths are like ABDM allows for collection of data from stakeholders. No, not at all. ABDM do not allow any collection of data. Because ABDM do not hold or store any data. This data storage is already kept, and it is stored in the hospital, clinics, and labs portal. Digitalization is concerned and will require some more time for doctor to do data entry. No, there is no need of data entry from the doctor's side. It is all digitalized. Once consent is done from the patient, doctor will receive the records immediately in the doctor's login in the EMR portal. Requires robust digital infrastructure to be part of ecosystem. No, the entities do not require any robust digital infrastructure to be a part. Anybody can be a part of this ABDM ecosystem. It tracks financial data, business information of doctor and facility. No, it does not track any financial data, business information of any doctor or facility, as it do not store any data. So some of the facts are, it provides security and privacy for healthcare data. Yes, it provides security, confidentiality, and of course privacy, because without the consent, data cannot be moved. So it is there is privacy, also privacy, because ABDM do not store any data. Voluntary registration processes there, and also allows the private parties to build tools and apps with various different features on the top of ABDM architecture. So what role you will play in the ABDM ecosystem? So partner with ABDM by registering on HFR, as I said, using ABDM enabled HMIS. So while you do the registration in HFR, it enhances the efficiency and ease of administrative functions, track key patient indicators and improve patient experience, and provide timely, accurate information about the doctors and the nurses. If you register on HPR and use in your daily practice, then how using ABDM enabled software doctors can use. So doctors will receive, create, and share digital records. They can follow up, track progress, and even refer the patient with ease, since the records are digitally transferred. Interact digitally with patients through telemedicine. Then encourage patient to create ABHA. So the benefits of ABHA card to the patient is, of course, easy access to their longitudinal records, easy access to online facilities like telemedicine, online booking appointment, online test booking, pharmacy, blood banking appointment, and everything. Now I'll move ahead with the integration process. Okay. So sandbox integration process, first of all, to get access there, so you have to log in and send requests to access the sandbox APIs. Once your application has been approved by the health tech committee, then you receive a mail with the client secret key, and so from there you can start with the integration process in the sandbox APIs. Once you are done with the integration process, and it has been approved by us by the internal demonstration flow, then you can move ahead for functional testing in VASA. And for functional testing in VASA, there are different agencies who do, like FIME, Sumasoft. You can reach out to them, and who will help you for FT. And for VASA, there are other organizations. So you have to submit us with once internal demonstration flow for M1, M2, and M3 are completed and has been reviewed internally, not by not the final health tech committee, only reviewed internally. Then you can move ahead with the FT and VASA. Once FT and VASA is done, you have to submit the FT and VASA certificate along with FT Excel sheet, the test cases to us, and then we'll review the same, and then we can push you for the final STC demo, then where you have to showcase the your M1, M2, M3 flow which you have implemented to our health tech committee. There are 4 members in our health tech committee who will look into the demonstration flow, the functionality and everything, and then they approve it. And once they approve it, you can go live and you'll receive the final production keys for the same. So currently it's available in all states and union territories. So this is in brief the sandbox integration process works. Okay, coming to the next slide, I'll quickly give you the brief intro about M1, M2, and M3 since you are a new integration process with ABDM ecosystem. So basically M1 is like creation and capture and verification of Abha. So you know why once you create, capture, and verify Abha, what it helps in QR code based fast track registration at hospitals. So once you create your Abha and everything is done, so in Abha app, there is a QR code, API also, which if you implement depends upon like, what is the stat of your hospital. If you have a longer, queue, in the hospital, then you can use the QR code based track registration hospital, which will decrease the stat of the queue in the hospital. And also, once you will implement Abha, you will create Abha number. So you will be commonly verified, identified among the government benefit programs. For M2 is basically, it's all about HIP, that is Health Information Provider services. So in M2, you link the patient health records with the Abha address. So the records are always, linked to the Abha address. So in M2, there are two important phases, that is HIP initiated linking and HIU initiated linking. So in HIP initiated linking, it happens when the Abha address is available with the HIP. In the hospital, when the patient goes to the hospital and provides the Abha address to the hospital then pushes the data for the same patient. And the data will fetch automatically in the HMI system of the hospital, where the hospital then re-verify that is it the same patient having this 14-digit unique number with this Abha address. This is how HIP linking is done. And the second part in M2 is very important, is HIU initiative linking, that is discovery of patient information by the patient himself. So when the user discovers his own records at the health facility that they have visited in the past, here the user have to log into the PHR app, search for the health provider that you have visited. For example, he have visited the hospital Apollo, Medanta lastly, and then by his consent, he will be sharing his demographic data with the hospital, with the HIP. So in M2 flow, you have to mandatorily implement both this HIP initiated linking and HIU initiated linking. So in the use cases, you can see why, if after implementing M2, what will happen, what is the use? The use is collation of health records in digital format in PHR app and health record. Of course, once you link the records, it will help the records to get digitally formatted in the app and health records, which you can access later on, even after 10 years and 20 years. So this completes with the M2 flow. In M3 flow, M3 is completely all about HIU, that is Health Information User Services, where to share the patient health records between the entities in the ABDM ecosystem. So M3 is all about the consent, CMP consent management, and all about like only how the consent is, patient will give the consent to the hospital, to the doctor will receive the data after giving the consent, even the notification part, how the doctor will receive the notification that the consent is granted or not. Again, in M3, there are types of consent, that is, the consent, like grant consent. There is denied consent. The patient may not, want to share the data with the specific hospital or the provider, the doctor. Then the patient will deny the consent. Or the patient, at times, what the patient do, at times grant the consent, and then he or she realizes that, okay, I do not need to show, now I don't feel like sharing my data to this specific hospital, this specific doctor. Then what the patient then log into the PHR, and the patient can what can do, he can revoke the consent. He can take back the consent, that no, I don't want to share now. Previously he gave the grant the consent, now the patient is revoking the consent. And deny, that the patient do not want to show the records to the provider. And yeah, that's all. These are three important, and also there is expired consent. A consent is can be applicable, can be seen by the provider, by the doctor, to a specific period of time. For example, if you are giving consent of your health record from like today's 1st June, so it is like health record from 15 June to 2nd June, from 15 May to 2nd June, sorry. So and the expiry is around like 15 June. So till 15 June only, the healthcare provider will be able to see the information, the health record the patient has shared. After 15 June, it will be expired. It cannot be seen by the healthcare provider. So this is all about M1, M2, and M3 flow in brief. I'll quickly cover like M1 flow, like what it was there previously, the creation, how you do. So in the M1 API flow, that is creation and verification. In creation part, you can create it by two ways, that is Aadhaar, DL, and other documents. Currently, you can only implement this create the Aadhaar number with Aadhaar and the DL only. For other documents like PAN and passport is yet under process. So there are three auth modes, authentication modes by Aadhaar, that is by OTP and by biometric and demographic. OTP is by simple done by the mobile OTP. The OTP will come to the mobile number and get authenticated. Biometric is done by two ways: fingerprint and by face auth, which is now live. And demographic is something which private entities are not using. It is specifically restricted for government entities. I can just give you a brief idea about what it is. It is like in demographic, you'll get, the hospital will get some feeds like a name, mobile number, gender, DOB, address. So the patient have to share these information with the hospital, and then automatically the Aadhaar number is created, and default Aadhaar address is also created. So, and in the verification part, again, same, this by OTP and the biometrics. Okay, so flow in milestone M2 and M3, which I have already discussed, like how it flows. So generate health records, link health records with Aadhaar, address, HIP initiated linking, user initiated is HIU initiated linking, then sending the data to PHR app for patient to view. That is the M2 linking. And in between M2 and M3, there is steps for data exchange on transfer, where the data exchanged is only done in FHI format, which I have spoken in slide number 3 initially, that you have to go and check the NRCS site for different FHIR standards bundles which you have to create, and also encryption and decryption of data over there you can create. And coming to the milestone 2, that is building of HIU, sorry, milestone 3, that is building of HIU, that is seeking patient consent, all the consent for data fetch, and where data push URL also is shared for the data transfer, and then rest data is received directly from the HIP, and then the acknowledgement happens and the receipt of data happens. So this is in short the M2 and M3 health linkage transfer of data works. Well, that's all about the webinars section which we have shown. We can start with a Q&A. Anybody have questions we can take up now in this session?
Hello, ma'am.
Yeah, hi.
Ma'am, I have one question. How we get HIP ID?
Okay, how you get HIP ID?
Yes.
Yeah. Sachin, are you there in the call?
Yes, Shabnam.
Yeah. Can you help with the HIP ID?
हाँ मैं वही बोल रहा हूँ.
Yeah, health information provider she's speaking about.
Okay. There is a API you can use the API and you can create your HIP ID. It is health information ad update services. Have you gone through the APIs or not?
I get client ID and secret, but third step
Yes.
is HIP ID. So how we
Uh,
can do?
HIP ID you will get by implementing the APIs. In
May I know?
Shabnam,
Yeah.
can you share the screen and guide him that where is the API in documentation?
Okay, I'm just interfering. Once you get your client ID and your secret, you need to register your services, isn't it? You need to register your services as an HIP, as an HIU. You register your services as an HIU because you have to share, link the record and share the health records. And as an HIU because you will be seeking to view the health records. So when you register as an HIP, then you get the HIP ID, and that is what you register. We have earlier it was on the dev link itself, add update services API, which Sachin has given. But now the link, we have modified the API. I am sharing on the chat the new API link and the API name. Okay, so that will help you with that.
Okay, but we are update URL for health provider URL. So in third step.
Yes, so your callback URL, if you go to Sandbox documentation, how to get started about APIs, if you read that, that is where you will see how to register your endpoint URL, how to register your HIP and HIU in order to get HPID and HIP ID, right?
Okay.
Yeah. And this API, which I have shared now on the chat, with that you can register your endpoint URL also.
Okay.
Okay. And in that API, you will also have get services API. So with that, you can see what services you have registered. I hope this helps.
Okay.
Yeah, any other questions we can take up?
No, ma'am. Thank you.
Yeah, then we can wrap up with the session now.
Madam, I just have one doubt. So suppose a hospital or healthcare facility is seeking information on behalf of a patient. So how can we ensure that the particular healthcare facility or hospital is storing that patient information locally? How can I ensure that thing?
Sorry, can you come again? I cannot understand. Like you're not clear.
For example, a healthcare facility is seeking some patient data on behalf of patient. For example, a patient visiting a particular hospital, so his particular doctor needs the particular patient's healthcare data. So patient give consent for accessing the data for the particular doctor. So how can we ensure that the data receiving from the gateways is stored in the or receiving the data? No, how can we ensure that that data is not stored in the local hospital? Because the healthcare facility is receiving the data. No, how can we ensure that that is not archiving in the local the receiving entity?
Shabnam, do you want me to take this query?
Yes, ma'am. Sure, ma'am.
Okay. Sureshji, what happens, first of all, what you said that data coming from gateway, that is absolutely wrong. There is no data ever stored or even passing through the ABDM gateway. Okay. And let us not use the word gateway. We call it as HIECM, Health Information Exchange Consent Manager.
Okay.
So ABDM only facilitates exchange of health record. Okay. There is no health record data ever stored in NHA, which I think Dr. Shabnam covered when she was telling about the federated architecture. Okay.
Madam, that I understand, madam.
Yeah. I'm coming to your question. I'm coming to your question. Okay. So what happens is whenever facility seeks data from another facility, so it is only for viewing purpose. It is not for saving, right? So ideally, it is totally on the hospital or the facility that they do not save it, by either by taking screenshot or by they should not be doing that. And we there will be regular audits from NHS side that the records are not being stored. Only those records the facility can store, which is generated by the facility, right? But
Yeah,
yes, coming to
yeah,
your
but
point, there is no 100% surety that you cannot, how can I give surety? Suppose, because the data exchange is happening between, say, for example, your Suresh Hospital and Dr. Shabnam Hospital, okay? So the data exchange is happening between you two. NHA will never know whether Suresh Hospital is downloading the data or taking a screenshot and saving. We will never know. But yes, the regular audits and checks will be there, and if found that data is being stored, because at the end of the day, Suresh is not the owner of the data. Either the patient is the owner of data or Dr. Shabnam is the owner of the data, right? So there is no way we can ensure. It is just that we educate that you should not be storing by taking screenshots or by taking a picture, clicking and all. But it is totally on the facility, and we have undertakings also. So facility do, when you go live, you always sign an undertaking. So it is totally on the facility that you should not be storing data. Yes.
Okay. Thank you.
I think, Shabnam, you can wrap up the session now.
Yes, ma'am. Okay, the recording will be shared in the Sandbox ABDM website. You can go and check. And we have other webinars also related to M1, M2, and M3. Please go and check the webinars before you start integrating with the APIs. This will definitely help. You can also write us with any queries and concerns in integration.support.nha.gov.in, or also write over dev forum and tag integration support so that we can get access to your queries and support you through your concerned issues, and also share your knowledge over dev forum, and so that other integrators can also get maximum help from your knowledge, and they can also help you in return. Thank you so much.
Shabnam, can you quickly show them the webinars, where webinars are there, where upcoming session details are there? Can
sure. Quickly share my session again.
Hello.
Yes.
Ma'am, can you repeat site name where we can download recording?
Okay, here we can just under sandbox.abdm.gov.in, you'll see for resources bar, and there you can see your webinars. And here in webinars, you can check for different kind of webinars over here. Webinar 7 for M1. We have M1, we have M2. We have webinars on FHI, data structures, validations, and everything. You can go through it for the same. For upcoming sessions, you can just go to the upcoming session over resource tab only, and you can check here that what other sessions are upcoming, and you can join the sessions over there. And I think you know about the documentation part for M1, where you have to go through. You have the link for the documents, and we have the Swagger links also. And for M2 and M3, we have building HIPs over here. We have APIs over here. We have document for HIP, same as building HIU. You have the same APIs and documents over here. We have postman collection for M1, M2, and health workers PHR. You can get it from here. And you can get started with with APIs, which the link which I've already shared. You can go and check out over here. And for integration exit process, you can check out over here. where you can go for FT and VASA. Everything is mentioned over this link. Yeah, that's all. Anything else? If not,
No,
then we
ma'am.
can
Thank
just
you.
wrap up the session.
Hello.
One more question. Can I ask one question?
Yeah, sure.
I just wanted to know how do you I mean when we went through that you were telling that data exchange of lab results and all should follow SNOMED, CT and LOINC. Is it that true or how is that? Can you explain on that?
Yes, yes, yes. We have to follow all these things. Meenakshi ma'am, can you please have a word for LOINC and everything?
Yeah,
if
Dr.
possible?
Dr. Geeta, can
Yes.
you just, I am sorry, I did not pay attention. Could you just repeat the question for me, please?
Actually, when we went through the document, we realized that the data exchange has to follow SNOMED, CT and
Right.
LOINC codes. So is it strictly implemented or diagnosis can be a free text or it has to
Yeah.
be, for example, discharge summary and
Yes,
lab
got it.
results?
Got it. Got
Okay.
it. Actually, Dr. Geeta, see I'm just going to a little flashback. See, the main vision for ABDM was that we could have, it will be user inclusive, and it will also be, one of the vision was also that we can have, we can do some kind of analysis which could help in pandemic, in time of pandemics, etc. So when you do analysis, you need data, right? And the data has to be structured data. That is the reason why we have said that when you follow the FIRE standard, in that you need to follow the SNOMED and LOINC. But right now it has not been mandated. The ABDM is not yet, mature enough. It still needs to be adopted. So we have given some time, about 6 months to I think 365 days or 6 months, I think, for this to be mandated. It's not yet mandated. So you can have your health records in unstructured format, which is in PDF format right now. That is pen and paper you write and then you upload it as a PDF format. Does that answer your question?
Yeah, that but in long run, since you are I mean, finally, when it comes to you have to have a structured data for
Yes.
sure.
Yes.
So, do you have any any help on
Absolutely.
facility available
Absolutely.
for example, LOINC codes? We were we were struggling actually with to match with our local codes. So do we get any help on that from ABDM in long run?
Absolutely, absolutely.
Yeah.
If you need any help for implementing SNOMED or LOINC, so we always connect you with NRCS team. So they always actually 2 or 3 of the integrators, they have taken help and they have implemented SNOMED after taking help from NRCS team. So that's absolutely not a problem. We'll provide all the support you need, Dr. Geeta. Just reach out to us.
Ma'am, that SNOMED is easier. So SNOMED is not the issue. Actually, the issue is the LOINC codes.
Yes.
Because each lab has got its own fancy descriptions. And I was going through the LOINC. I found it.
Yeah.
LOINC really needs help because SNOMED is definitely more, it's more easy and to implement. But LOINC, that very much, different. Even microbiology, if you go through the terminologies, so much they use in a different way. And mapping is really a tough job. So I was just wondering whether somebody can help on.
They can help. I think
Yeah.
if you can, I have sent an email. If you write to them, they will certainly help. But then they will also ask, have you integrated with ABDM or are you integrating with ABDM? But yes, NRCS can always help. You can write an email to NRCS and put us in CC. We will definitely take it up.
Thank you.
Hello, Mr. Suresh.
Great, then we can wrap up with the session. For any queries, please write us at integration.support. And
Hello.
yeah.
Yeah, Dr. Shabnam, there was a question from Mr. Suresh that I think I just wanted to ask him, is his query is resolved or not? I think he is asking about how can he ensure that HIP is having the data.
I think Meenakshi ma'am has already covered with the query.
Yes, yes. I'm just asking Suresh that
Suresh,
Yeah, yeah,
are you
yeah,
there?
yeah,
Suresh?
yeah,
uh,
yeah. It's all,
what?
it's all. Yeah, it's addressed,
Okay.
addressed. Yeah.
All right. Okay.
Yeah, anything else, Sachin, you want to speak?
No, thank you.
Yeah. Then I think I will wrap up the session. It's already 1. So yeah, thank you so much, everyone, for joining the session and taking out time. You can write us at integration.support for any help. Thanks a lot.
Thank you.